Okay, so all right. So we can start. So this is a poll that just put up two questions to see what we can give as our answer. So the first question was talking about that cancer cachexia is reversible. Is it true or false? And almost everybody said yes, it is reversible. Okay, quite interesting feedback. Susan, why do you think it is reversible? Let me start with you. Is it reversible? Susan Onyango, if you are able to unmute. Okay, Susan is quiet. Mary Mwangi, you can hear me? Is it reversible? Why do you think so, in your opinion?
Okay, I think it's reversible simply because anytime you're having muscle loss, it's always easy to like bring it back with the right interventions. Yeah, that's just my thoughts.
Okay. Quite interesting. Okay. Chetna, what do you think? Chetna, do you think it is reversible?
Yes, I think it is reversible. I don't know much about it, Mr. Okinda, but I just, as per the definition of cancer cachexia, because I'm not an oncology student, like I have not done any specialization in oncology, but
Yes.
still, because it is due to, it's related to improper intake of food, basically. So, altered metabolism and all those things. So, I think if a proper nutrition intervention is done,
We can
it can be reversed. Yeah.
Okay. Thank you. Great to hear that. Lydia Nasimiu, what do you think?
Hello, Mr. Kinda.
Yes.
Okay, I think it's reversible during the initial stages of where the cancer cachexia is setting in. If we approach it as a multidisciplinary, like we give a multidisciplinary approach, we can be able to reverse using different medical intervention and nutritional intervention. We can reverse that condition.
Okay. At the initial stages. Yeah. That is your feedback. Okay. Lynn Odero, what do you think? Do you think we can reverse it? Majority of you are saying that we can reverse cancer cachexia.
I think it can be reversed. I think it's reversible. Yeah, I think with proper intervention, I think it can be reversed. Yeah, it might take a while to be reversed, but I think it's reversible.
Ultimately, we can reverse it. Okay.
Hi, Ken.
Yes, Susan.
I just stepped out a bit. I've heard you call my name.
Yes.
Would you kindly?
We are asking. We are asking. We voted here. The first question was cancer cachexia is reversible. So, and the majority have said it is true. So I wanted to ask you, do you think it is reversible? Can we reverse it?
Well, I'm not an oncologist or nutritional oncologist per se, but I think it is with early interventions. If we optimize nutrition interventions and then probably with the exercise regimen and other medical or directed treatment. I think, yeah, it is reversible in the earlier stages.
Okay. Thank you. Penina Wangoi, karibu sana. Welcome. We've just started. So we were just having this voting process to see whether cancer cachexia is reversible. So majority have voted yes, true. Yes, so based on this statement, yes, you can say it's true because as you've said, Susan and Lydia and other team members, at early stage we'll be looking at stages of cancer cachexia. We can reverse it at that moment, but there is a stage where when it is already reached a full blown, then we can't reverse it. So at the precachexia phase, we can reverse that. So we'll see that in the presentation as we continue. The second question we were looking into was management of cancer cachexia is a multimodal approach that require multidisciplinary efforts or just nutrition intervention. And I love your answers. Majority have said it is true. And I totally agree, it is true. You need to have a multidisciplinary approach to manage it. We'll look at those ones in tomorrow. We'll be able to look at the medical therapy for management of Cancer Cachexia Syndrome. So you'll understand that there's a role nutritionists play, there's a role palliative care team play, there's a role medical oncologists play, pharmacists play. So it's indeed a multidisciplinary efforts to really intervene or manage it. Wow, thank you for that. Allow me to now share my screen so that we can go deeper. I want us to take at least not more than 1 hour because of the presentation we have. Then tomorrow, so today we'll cover as much as we can. And then, of course, tomorrow, God willing, we'll be able also to finish up. And I want to, first of all, to thank you all for joining this two-day webinar. It is going to be quite an interactive session. You are going to learn a lot. And I'm glad after this, you'll be able to support your patients adequately. So that is who I am. My name is Ken Okinda. I'm oncology nutrition specialist. That's my background, registered by Kenya Nutrition and Dietitians Institute. I'm also a research officer, having actively participating in research projects. So today, I'm glad to welcome all of you to this important series that we are going to have for the next 2 days. What we are going to tackle is going to be able to help us manage our patient well. And my main objective for this webinar is try to prevent cancer cachexia before it sets in. So prevention is going to be very key because once it's set in, it is a 50-50 chance that it can be reversed. So let's go straight to the definition. So when we talk about cachexia, it is a Greek word. It's a Greek word that means kakos and hexix. So it has two differences. So the first one is kakos and the next one is hexis. So the word cachexia is a Greek Greek origin, and basically it means poor physical state. So that is what it means in a nutshell when we're talking about cancer cachexia, poor physical state. So cachexia is a multifactorial disease characterized by weight loss via skeletal muscle and adipose tissue loss, an imbalance in metabolic regulation, and reduced food intake. So when we are talking about cancer cachexia, when we are talking about cachexia, any time you hear about it and you've seen a cancer patient, just start thinking about weight loss, mostly in the skeletal muscles. So that is the most prominent one. Then, of course, we are going to experience what we call adipose tissue loss. So that is also another thing that we are going to have to experience for our patient. We are going to have imbalance metabolic regulation, and we'll be able to see that. And then lastly, these are patients who experience also reduced food intake. So these are usually when we talk about multifactorial disease, it basically means it's a mixture of so many problems. you can't pinpoint one problem that has caused the cachexia. So it is a combination of so many factors that are linked together. So what you need to have in mind is one is the aspect that this condition is associated with the aspect of weight loss, adipose tissue loss, an imbalance in metabolic regulation, and reduced food intake. So all these are what refer to cachexia. So that is basically the definition of cachexia itself. Then now when we come to cancer, we are saying it is a multifactorial host phagocytic syndrome, and it is characterized by continuous decline in skeletal muscle mass with or without fat loss. So whereas we are saying in cachexia, we are having adipose tissue loss, for cancer patients, they can either have fat loss or some of them will not have fat loss. You'll have extremely decline in skeletal muscle mass, but mostly sometimes you can find fat loss is not there. And of course, in some patients, there will be a fat loss that will be reported. So I hope up to that point, we are getting it clear. For those who have just joined us, we've just started, so you don't have to worry that we have gone. So it leads to progressive functional impairment. So first thing that you'll see for patients who have cancer cachexia or definitely cancer, the first thing that when you look at them physically, you'll see is that they are quite wasted and they are also weak. So with cancer cachexia, we are going to have quite a progressive. It doesn't just occur once. It is something that occurs continuously, functional impairment. And then, of course, they have weakens the effect of chemotherapy. So because of the cancer cachexia, you find that now the treatment, which most cancer patients undergo, the chemotherapy, becomes very ineffective because many a times the medications need to go via inside the cells, and with the reported severe muscle loss and muscle wasting and fat wasting, you'll find that the chemotherapy might be very ineffective. And of course, there is increases mortality in patients with cancer. So it is very rare, really, to find most of cancer patients who with mortality and they have died when their muscle mass is intact. Usually, it is rare to find such patients. So that is where they reach into that point. So cancer cachexia is caused by factors of catabolism produced by tumors in the systemic circulation. So majorly when we are looking at cancer cachexia, we're looking at the metabolic catabolism. So we have two metabolic definitions. One is called anabolism. Anabolism is basically the buildup. For example, when you are eating enough adequate nutrients, you are building up your body. And so that one we term it as anabolism. Then catabolism is now breaking down. How the body functions is that when you have enough intake, then it stores for future use. So in that point of storage, you are building up. For example, if you take excess carbohydrate, it is converted into glycogen and stored in the liver and also in the muscles. So same applies to when you do excess fat component. So in cancer cachexia, we are having a catabolic process ongoing and this one is produced by tumors in the systemic circulation. So basically what we are talking about is that the tumor itself has the ability to produce chemicals within the circulation, and we look at them, we call them cytokinins. So these cytokinins have ability to cause the catabolism. So as well as physiological factors such as imbalance inflammatory activation. So imbalance inflammatory activation, will be looking at what we call C-reactive protein, which is quite produced in the aspect of acute phase of illness. We have also what we call proteolysis. So basically, it's the breakdown of the stored proteins. You find that it's being broken down to give energy when we have inadequate intake of carbohydrate. So that is quite also one of the commonest thing that cancer patients experience. Then, of course, we have what we call autophagy. So autophagy basically is the consumption of body's own tissue. This is as a result of a metabolic process occurs in starvation and certain diseases. So you find that the body kind of fight its own self, or it mostly start destruction of or damage of cellular component of the body. So that is what we call autophagy. And then, of course, lipolysis is the breakdown of fats to give energy. So that may occur with gastric, pancreatic, esophageal, lung cancer, liver, and bowel cancers. All these cancers have a capability of causing that. So because cancer cachexia cannot be easily distinguished from anorexia and other causes of weight stroke muscle loss, it is defined by an ongoing loss of skeletal muscle mass with or without fat loss that can be partially but not entirely reversed by conventional nutritional support. So just to answer the question that we had put in our poll is that um, we can reverse the cancer cachexia, especially in the initial phase. That can be reversed, but it can be reversed partially, not completely. For example, if you're already at the what we call the refractory phase, it can be able to reverse it at that point. But when now we have full-blown cancer cachexia, then that one we cannot reverse it. So we are saying basically that if you have a cancer patient who already is either on chemotherapy treatment and they are not eating adequately, then you expect them to have a cancer cachexia syndrome. So we are saying that once cancer cachexia syndrome has set in, we can partially reverse it, especially in the initial stages where we refer to it as refractory stages, we can reverse it. But majorly, it is hard to reverse it when we are talking about when you want to only have conventional nutritional support, you might not be able to reverse it. The physiological characteristics of disease are negative nitrogen balance and negative energy balance due to reduced food intake and abnormal high metabolism. So how our body functions physiologically is when we have adequate nutrient intake, what happens is that the body will be able to utilize what it requires to run what we call basal metabolic rate. This is now the energy that you require to do day-to-day activities. So if you eat more than you require, then the body, especially the carbohydrate, will be converted into a protein called glycogen and get stored. So glycogen is a form in which carbohydrates are stored in the liver and also in the muscles. So they are also in form of a protein. So it is expected that we have what we call positive nitrogen balance. What we define by positive nitrogen balance is that the nitrogen that you are taking from the diet, what we term as exogenous nitrogen, and the one that the body is able to produce through synthesis, what we call endogenous nitrogen, there should be a balance between the input and output, so that you don't have nitrogen, you don't have proteins being negatively reported. So what happens is that we want to be in a situation where when what we eat and what is being broken down to build the body and also to function, there is an equilibrium. But in cancer cachexia, there is a negative nitrogen balance, meaning that the body is breaking down a lot of nutrients that have been stored in form of proteins than it is building up from the diet. So when we have that negative nitrogen balance, that is what makes the patients to start experiencing wasting syndrome. Okay, I hope we are following. Are we together up to that point? I want to take you through step by step of this stage. If you're together, kindly let me know. Great. So we are continuing. So let's look at some of the prevalences of cancer cachexia. So we've seen some of the cancers that are quite common with cancer cachexia, but we are saying that the prevalence of cachexia is as high as 87% in patients with pancreatic and gastric cancer. So Pancreatic and gastric cancer are one of gastrointestinal tract cancers. They are quite hard to manage. These types of cancer literally will affect your nutrient intake. Either it will affect your digestion system, or again, it will affect the absorption. So it is quite high in patients with gastrointestinal tract cancers. That is the pancreatic and also the gastric cancer. But we are also saying that 61% in patients with colon, lung, and prostate, and what we call non-Hodgkin's lymphoma. So it's also quite a higher percentage in that. And then, of course, for patients with breast cancer, sarcomas, and leukemia, Hodgkin lymphoma, 40% of them experience cancer cachexia, that is wasting syndrome. So you can see that almost majority of patients will have cancer cachexia at one moment if it is not well taken care of. In overall, cachexia accounts for 20% of all cancer-related deaths and is a sign of poor prognosis. So anytime you're seeing a cancer patient who is wasted, who has severe muscle wasting, then the possibility, what we call the expectant life of that patient is really low. So almost 20% of cancer deaths are caused by cancer cachexia. So you can imagine, wherever we think that maybe, of course, some of the causes of mortality for cancer could be the tumor itself. It could be the result of treatment modalities like chemotherapy, radiation therapy, if we have treatment failure. And of course, we have poor immunity and all that. But you can imagine 20% of all cancer-related deaths are associated with cancer cachexia. So it is important for us to really study it in details and understand what it means and how we can prevent it before it sets in. Then cancer cachexia develops as secondary disease in patients with cancer and causes progressive dysfunction characterized by systemic inflammatory response, negative protein energy balance, and involuntary loss of lean body mass with or without decline in adipose tissue. So it doesn't just come as a primary disease. There is no way we'll have cancer cachexia as a primary disease. What I mean by primary disease is that it's the major cause of body dysfunction. So you'll find that a patient, first of all, will have cancer itself. And then as the disease progresses, then the patient start experiencing cancer cachexia. That's why we refer to us as a secondary disease in patients with cancer. And of course, we've seen that it is a progressive dysfunction. There's a systemic inflammatory response. This one, we'll have a look at it in detail. So what we mean by systemic inflammatory response is that when somebody has acute illness, what happens is that the body starts to react to fight that kind of illness. The reaction of the body will automatically lead it to produce antibody against the foreign object, the antigen. So that is going to cause what we call systemic inflammatory process. And for us to confirm the extent of systemic inflammatory response, we do a test called C-reactive protein, CRP. So when CRP is high, then it tells you that the level of disease is quite high, and the body is trying to fight to beat up the disease. Then, of course, I've explained on negative protein energy balance as one of the side effects of cancer cachexia. We have involuntary loss of lean body mass. So what we mean by involuntary is that you are not, you are like, even if you are obese and you have cancer, or you are overweight and you are having cancer, but you are not intending to lose that weight, and then you start losing it, then that is what we call involuntary loss of lean body mass. Then, of course, we have with or without decline in adipose tissue. So weight loss, loss of appetite, growth disorders, and decreased muscle mass are the main symptoms of cachexia. So when a patient they have cancer and they start experiencing severe weight loss, we look at those weight loss category. They start losing appetite. They have growth disorders, especially in children. They are not growing well, even if they have a disease. And then they have this decreased muscle mass. Then you can be rest assured that we've started dealing with cancer cachexia syndrome. Let's move on to the next slide. Now, let's look at what we term as pathophysiology of cancer cachexia syndrome. So what we mean by pathophysiology is how does it occur? What really goes on in the body that lead us to have Cancer Cachexia syndrome? I understand maybe in this forum we might not have those who are quite versed with medical terms, terminology, and also the medical issues. So it is important that I simplify this so it gets synced on. And I know some of us who are also practicing might not be able to understand pathophysiology in details. So basically what we mean by pathophysiology is the disease progression process from the time the onset of the disease as it continue to progress. So how Cancer Cachexia syndrome starts? It starts with what we call acute starvation or what we call dietary deprivation. So when somebody is sick naturally, they tend to eat less or they tend to avoid food. All right. So that process of avoiding food or in a process where they are now either eating but they are not eating enough, then in that situation we are having we are having severe deprivation of food. So when that occurs or severe starvation, it is characterized by loss of body fat and preservation of muscle mass. So at the initial stage of starvation, we find the muscles being preserved. All right. I want us to understand this point very clearly so that we can see how we can help our patient. So when somebody is deprived of food, let's say is starved food, the first contact, what the body does, the body start breaking the fat to give the energy, because the main source of energy in the body is carbohydrate, which we eat from ugali, from chapati, from rice, and all that. So in a situation where you are not getting enough carbohydrate, since the body has a mechanism of storing excess for future use, then there will be loss of body fat at the initial phase. So because fat will be broken down to give us energy. All right. So inadequate dietary carbohydrate intake leads to mobilization of what we call triglycerides from adipose tissue. So you will find that the fats that have been stored within the abdomen, within the muscles, within the organs, they start being broken down to produce enough energy. All right. So triglycerides, this is the form in which fats exist. They exist in three glycerides and three glycerides molecule. So triglycerides are broken down into what we call a glycerol and free fatty acids. So the latter, that is the free fatty acids, which are used for energy by most of the body's cell. So I'll explain this in successive slide, but in a nutshell, what we are talking about is that we are not when you are not able to eat adequate carbohydrate, what the body does is start breaking down your fat to give energy. And the form in which the fat is stored in the body is called triglycerides. So for the body to use that fat, it has to break down the triglyceride to give us what we call glycerol and free fatty acids. So glycerol, free fatty acids are the one that are going to be broken down to give us energy. I hope up to that point we are clear. Then now, as lipid mobilization is accelerated, so basically what it means that you are not eating enough carbohydrates. So your body has resorted to use fat to give us the energy. So there's going to be an acceleration in terms of mobilizing fat for us to have enough energy. That is what we call lipid acceleration. So meaning there's going to be increased requirement of lipids to be able to produce. Lipid is the same as fat to be able to produce energy. So the balance of what we call lipogenesis. Lipogenesis is the process by which when you take excess fat that the body does not need, then the body will convert that fat into triglyceride, this one here, and store it. So that process is called lipogenesis. And then lipolysis is the process by which now when you are not eating enough fat and also you are not taking enough carbohydrate, then the body will be able to break down this triglyceride, which it had stored during lipogenesis, into glycerol and fatty acid to give us energy. So when the balance of lipogenesis and lipolysis is upset, meaning that it has been affected, so you'll find you'll have increased lipolysis activity than lipogenesis activity. I hope I'm not confusing you people. Are we together? This is quite important for you to learn. Let me see.
Can you please repeat the definition of lipogenesis and lipolysis, please? Once again, I
Okay.
request.
Okay, thank you. So basically what we are saying, when you eat excess carbohydrate, it is converted into glycogen and stored in the liver and also in the muscles. When the storage is complete and still there is excess carbohydrate in your system, the body will convert that excess carbohydrate into what we call triglycerides, that is fat. That's why you find people who are consuming excess carbohydrate, they are either obese or overweight. All right. And the fat are usually stored within the abdomen and also in the visceral organs. Visceral organs are the heart, are the liver, and the kidneys, and all that. So, what happens is that the process by which the body converts excess carbohydrate and even excess fat into triglyceride. The triglyceride is the form in which the body stores the fat. That process is called lipogenesis. All right. Then lipolysis is when now you are not eating enough fat or carbohydrate from your diet, yet the body needs to function correctly. So lipolysis is the process by which the body breaks down the stored fat triglycerides into glycerol and free fatty acid. Chetna, is that okay? Is that understood?
Yes, Doc. Thanks a lot.
Thank you. So now, what we are saying, when the balance of this in a normal situation, in someone who is not sick, the lipogenesis and lipolysis is at equilibrium. That means that the process by which the body is storing, is converting fats into, excess carbohydrate into fats and store it in triglyceride, and the process by which the body breaks the excess fat to give energy, they usually are balanced. But in a situation of cancer or when we have acute illness, that balance is upset and free fatty acids are released into the blood. So the free fatty acids are the ones that are going to form energy. Remember, we had said that the immediate source of energy for the body is carbohydrate in form of glucose. So when you are not eating enough carbohydrate because of illness like cancer, for example, your body has a mechanism of still functioning and it will break down the stored triglycerides into glycerol and fatty acid. So this fatty acid is what gets into what we call Krebs cycle to give us the energy in terms of ketones. Thank you. So in contrast to starvation, individuals with cancer cachexia can experience a loss in adipose and skeletal muscle mass, while visceral mass is preserved. So I need to explain this too. So since we are saying that triglycerides are stored in the abdomen, in the heart, and other vital organs, the main component part in which the triglyceride will be broken down was from just adipose tissues. But the visceral fat, this means that this is the fat that is surrounding the vital organs like the heart and the liver and all that, which provide what we call insulation, because the fat is not bad. Fat also has a better function in the body. They provide that insulation in the body. They are also they are also helpful in terms of transporting fat soluble vitamins. So what happens in cancer starvation or in starvation in cancer patients, we'll find majority of this triglyceride will be broken down from adipose tissues. However, the visceral fat is preserved. This is not the case when you're comparing from starvation that occurs, which is not characterized by cancer. For example, the children in Turkana, for example, you'll find they are so wasted when we're looking at malnutrition, protein energy malnutrition. Even their visceral fat is usually affected because of protein energy malnutrition. So that is usually the difference. So weight loss not reversed with increases in nutrition intake alone, and weight loss despite increased intake of nutrients. So for cancer patients, you'll find that you might not be able to increase weight loss by nutrition diet alone. Okay, so that is something that also you need to connect. We are still looking at the pathophysiology, how cancer cachexia set in. Whatever you are seeing by your own eye, majority of cancer patients are quite wasted. whatever you see is an outcome of so many processes that have already gone internally in the body that you cannot see by your own eye. So what I'm teaching you today is to give you an insight of what goes on in the inside of the body. Now, the liver is one of the organs in the body that is mostly used for breaking down or doing the activity of metabolism. So what the liver does, it converts free fatty acids to what we call acetyl-CoA. I will not might go through deeper into this because it's quite a medical complex terms, but I'll just explain in a layman's language so we can all understand. So what the liver does, remember the free fatty acids that have been broken down from triglycerides in our previous slides, they are converted into energy into what we call TCA cycle. So the problem with the use of free fatty acids is that too much acetyl-CoA, this is the form in which the fatty acids are broken down, is formed, and excess that cannot be processed by TCA is used to produce ketone bodies. I need to take 1 minute here to explain something. You hear nowadays people talk about ketogenic diet in terms of weight control and everything. Basically, what they are talking about is the aspect of ketogenic diet. We are talking about the aspect of producing ketones at the end product. So there's a question here: in lipolysis, we yield glycerol and fatty acids. So where does glycerol goes since fatty acid is that? Oh, great. That's a good question, Joseph. So basically, what happens with the glycerol? Glycerol still gets back to the system, and it's also used to form another triglyceride. So it is still a free component that still goes into circulation and looks for another free fatty acids to form triglycerides. So it is one of the components that still is being used in that component, in that cycle system. So what I was trying to, many people currently are using ketogenic diet in form of losing weight. But I don't want to dig into that in terms, because today we are discussing cancer component, but I want to give you my opinion. So ketogenic diet is good, especially also when we're looking at the aspect of disease control, even for stage 1 cancers, because the aspect that cancer cells consume sugar is true. They consume glucose. So if you're giving too much of carbohydrate, especially for stage 1 cancers, where you can limit amount of carbohydrate you're giving and increase amount of fat, so that the cancer cells are not able to utilize the ketones, which is the byproduct of fat metabolism. All right. So the heart and skeletal muscles are able to use ketones as energy. So after a period of time, even the brain adapts and is able to convert ketones into ATP, what we call adenosine triphosphate, but the liver cannot. So this statement, basically what it means is that when we are not consuming adequate carbohydrate, what the body does, the body will resort to break down triglyceride, which is fat, to give energy. Now, the byproduct of fat metabolism or breakdown is called ketones. Now, the heart and the skeletal muscles are able to use ketones as energy. However, the brain, which also takes a major part of the food that we eat, at still initial phase is not able to use the ketones the way they are. That is because of what we call brain barrier. So the ketones are not able to get through the cerebrospinal fluid into the circulation of the brain. But as you continue to deny yourself carbohydrate, then you are still having the byproduct of ketones. The brain will start adapting to use ketones. That's why for patients, for those, not only patients, but for all those people who are what we call what those patients who or clients who are practicing ketogenic diet, for the initial stage of starting it, you find many a times what happens with them is they start experiencing severe headache in the starting point, because now the glucose is not able to get into circulation because they deny themselves eating enough of carbohydrate. And as the time goes by, now the headache will start going down because now the brain will start utilizing the ketones in terms of ATP. So that is what I didn't want to explain it in terms of cancer, but this is basically what happens. So during starvation, the plasma ketone concentration increases as the production of ketones surpasses the level at which the heart and skeletal muscle can oxidize it. So we will find that when cancer cachexia syndrome or patients with cancer who are not eating adequately, you'll find excess circulation of ketones in their system, and then that can be more than what the body can utilize. So the energy metabolism is related to intimately to carbohydrate, protein, lipid metabolism, all of which are affected by tumor growth. So as tumor continue to grow, then of course we have carbohydrate, protein, and lipid being affected. So alterations in metabolism when cancer is present can impair nutritional status by depleting the body's protein, fat, water, vitamin, and mineral store. So here now is what if we have continuous starvation. Continuous starvation is that this our patient has cancer and it has affected their appetite. They are not eating enough, and these patients have not been referred to a dietitian or a nutritionist to plan for them their meal. You find that many a times dietitians and nutritionists will meet cancer patients at the stage when already we are having stage 4 disease. And when that happens, we cannot reverse cancer cachexia. There's nothing that we can use to support that patient. So if we are able to intervene at the earliest stage where you've noticed that this patient is not eating enough, then what happens is that you can be able to do what? To support that patient, even provide what you call oral nutritional supplement to meet the demand that the patient is not having adequately via diet. So if we have continuous starvation, continuous deprivation of energy, and some people also tend to starve cancer patients because of the myths and misconception. For example, people will say, "Oh, if you have cancer, you're not supposed to take sugar," for example. So they start starving the patients. Deny patients some food. You're not supposed to take meat, red meat, for example. Of course, we have different types of cancers where, especially when you're talking about early stages, then you need to limit some food intake. But if you just decide to limit food intake for cancer patients without being guided well, then you are depriving that patient adequate nutrients, and that is what is going to lead to cancer cachexia. So this is evidenced by the way some tumors can exert a constant demand for glucose. Of note is that more recent studies using indirect calorimetry have shown that the long-held belief that all patients with cancer have increased energy expenditure are simply not valid. So it is not true that indeed that all patients who have cancer have increased nutrient intake. Of course, the disease is there, but you can still give them the normal energy intake, and that will be enough to sort them out. Malignant cells can exhibit a high rate of anaerobic metabolism, which yields lactase as a byproduct. So now, malignant cells are basically cancer cells which have ability to spread. So what they do, I wish I could have time to explain to you the how cancer comes in and how malignancies comes in. So malignant cells, of course, these are the cells that are capability of multiplying and also spreading to other distant organs. They usually also, in their own form, they release chemicals in terms of through the anaerobic metabolism that is called lactate. This also affects the lactic acid pool requires an increased rate of host gluconeogenesis. So gluconeogenesis basically means the formation of glucose from non-carbohydrate. For example, if we are saying you looked at the aspect where we are having lipolysis happening, the byproduct of fatty acids being used for energy, that is the process we call gluconeogenesis, formation of new glucose from a non-carbohydrate. For example, if you're not eating adequate carbohydrate from diet, the body will convert glycogen in your liver and have glucose. So that process might call gluconeogenesis, formation of new carbohydrate. So lactic acid get into the what you call Cori cycle, and all that also have aspect of causing cancer cachexia. So both protein breakdown and lipolysis take place at increasing rates to maintain high rates of glucose synthesis. So in a nutshell, what we are explaining is that if the patient has cancer and is not being adequately fed via the mouth, and then we are not having nutritional intervention at the earliest phase, what you need to understand is that the body is breaking down the stored component, that is the fat and also the protein. And when this occurs, if we have continuous, and this can occur very fast, because remember, tumor also feeds on this on glucose. So if you are not able to, so the body demands glucose, tumor also demand glucose. This is why you find that now it's reached a point where the body has been so much overwhelmed because you are not feeding him, and yet the tumor is also growing and there's a higher demand. Additionally, metabolism may be affected by hormones or substance produced by tumor or body in response to tumor. So one thing you also need to understand is that tumor has capability of producing its own hormone, okay, which mimic the hormone of the body. And this is why you find cancer is complex to treat, because in a scenario where now we have an hormone called antidiuretic hormone being produced by the tumor, and the body still produce antidiuretic hormone, and this hormone is responsible for regulation of sodium in the body. So you'll have excess production of antidiuretic hormone. And in oncological emergency, we term it as syndrome of inappropriate antidiuretic hormone. So in that situation, tumor itself, cancer tumor has capability of producing its own hormone, which are more like the same hormones that the body produces. Up to that point, are we together? I want to understand that all of you are we are on the same page, and you are learning something. I'm sorry, today might be quite technical in terms of medical jargons, but tomorrow we try to simplify when we are looking at nutritional management. Kadomi Mutembei, how are you doing? Is the class making sense for you today?
Hi, Ken. Good evening.
Hi.
Yes, yes.
Great.
I'm learning a lot. Thank you.
Great. Mr. Nyariki, how are you today? Are you able to hear me? Are you faring on?
Yes, I'm following.
Okay.
I'm also learning a lot.
Oh, great.
I didn't know the body has so many functions.
Yeah, of course it has. It will be interesting to see as we move forward how this happens. I know majority do see cancer patient wasted, but they do not understand how that comes in, and that is the science I want to bring to you, so that when we are going to manage those patients, we know what to target. We don't just manage them blindly as other person. We have to understand what already is happening in the body. And again, it's important to understand also the stage by which they are in. So that will help us to intervene appropriately. This same concept is applied also for chemotherapy treatment once we have understood the stage by which they are in. So now, the metabolic changes of cancer cachexia may influence both protein and fat metabolism. They may be both host and tumor factors that reduce protein synthesis and increase protein degradation, resulting in preferential loss of skeletal muscle mass. So all those factors that I've explained in the previous slides has capability of reducing the protein and energy intake. Then fat stores in the body are mobilized, possibly as a result of negative energy balance, but also due to the action of intermediary metabolites. So intermediary metabolites, we are saying these are products that are being produced as a result of tumor itself, such as lipid mobilizing factor. So you find that because we have a higher demand of lipid in the circulation, the body has capability of producing what we call lipid mobilizing factor to mobilize adequate lipids to be used for energy. Remember, this is a situation where the patient is not eating adequate carbohydrate from the diet. So now the body has to form its own mechanism to survive. The disease is all overwhelming it. You are not feeding enough, so the body has to put up the mechanism. So all this also, like lipid mobilizing factor is also one of these are factors that help in mobilizing lipid. Then of course we have tumor necrosis factor, alpha. So this is an product, a chemical that is produced by tumor itself. We call them cytokinins. So in most cancer patients, high serum C-reactive protein. So you'll find majority of cancer patients undergo at the initial stages when they are met, the doctors will or medical oncologists will request for a C-reactive protein. So a C-reactive protein, as we've seen in the previous slide, is helping us to know the extent of the acute illness. So when a laboratory test of a C-reactive protein is ordered, we are basically looking at how bad is the disease damaging the cells, or how bad is the body trying to fight that. So the higher C-reactive protein indicates that this patient is undergoing acute phase of illness and the immunity is going down. So, and again, when we have acute infection or illness, we have what inflammatory processes that are happening inside the body. And that's why sometimes you find the lymph nodes are swollen. Yeah. So that is a secondary to a reaction between the body immune function trying to fight the disease itself or the disease causing organisms. So a high C-reactive protein, a measure of inflammation, is also associated with weight loss, which indicates that changes in dietary intake and inflammatory response are both present in patients. So you can imagine if patient has cancer and still is not eating adequately, you can imagine the kind of fight the body is having at the same time. And that's why you find most cancer patients go down very fast because of what is happening to them inside of the body. So currently, lack of studies specifically measuring metabolic rate in cancer patients prior to treatment make it difficult to ascertain the relative contribution, if any, of these metabolic changes on energy expenditure and potential weight loss. So studies are currently not so adequate. I'm currently involved in conducting a study for patients who have esophageal cancer. So we are looking, sorry, we are looking at Cancer Cachexia Syndrome for esophageal cancer patients. So my study has already gotten ethical approval, and I'm at data collection phase just to look at the prevalence and the causative agent of Cancer Cachexia Syndrome for esophageal cancer patients. Now, I might not dig deeper into this, but this is a summary of what I was explaining to you in the other slides. So we have glucose production from storage sites. So this is a situation where you are not eating adequate carbohydrate from your diet or adequate nutrients. So what the body does, so there's a storage already. So glycogen, this is the form in which glucose or carbohydrate is stored in the body in form of in liver. So glycogen, when you are not taking adequate carbohydrate from your diet or adequate nutrients from your diet, then this glycogen is going to be broken down called glycogenolysis, breaking down of glycogen to give us glucose. I want to repeat again. The body can only utilize the form in which the body uses energy is in glucose form. And when I'm talking about glucose, I'm not talking about the ile glucose ya duka tafadhali, the one that we are using for sports. And no. We are talking about blood glucose. This is as a result, when you take adequate nutrients, it's converted into blood glucose. That is what we talk. Even if you take sugar, sugar will get into the circulation and get converted to blood glucose. So blood glucose is the form in which the body utilizes carbohydrate. So don't confuse this glucose thing with the glucose you are getting in your shop when somebody is running a race and their energy has gone down. So they take, of course, that is also one of it. But now, in this context of science, glucose is the form in which the body uses the carbohydrate or the nutrients. Now, so we find glycogen getting into the circulation, broken down through the process of glycogenolysis. We have the end product of glucose. Then, of fat triglyceride. Remember what is it called? The lipolysis. Chetna had asked about it, breaking down of triglycerides into fatty acids and triglycerol. And remember, fatty acids get is going to be converted into glucose. Then glycerol goes back to the circulation to form to combine with another fatty acids which are free flowing in the circulation to form triglycerides. So glycerol goes through the process of lipogenesis. Or I hope that's okay. I think Koini had asked about that question and I wanted to clarify. Then liver and muscle protein. So these are the protein that are stored in the liver. They are also being broken down through the process called gluconeogenesis. You remember we had talked about it. Formation of glucose from non-carbohydrate, gluconeogenesis. And all this will give us glucose. So if we have continual breakdown of these three components, muscles start to waste, fats are being broken down, and then if we are not able to intervene at the early phase, then we'll have cancer cachexia syndrome. So that's why you see cancer patients are severely wasted because of this process. There is no one who is able to intervene to them adequately to support them. So if you are going to manage that patient and you've not understood this science, then you'll manage that patient wrongly. You'll prescribe a diet which is not going to help, because you now need to know, what do I need to target? All right. So I hope that is okay. So this is what we call it goes to Krebs cycle. Then of course we have Cori cycle. This is another, what we were explaining is still the same concept, where we have blood circulation here. We have the liver muscles, so they are getting into circulation, being broken down, and the cycle continues like that, like that. Now, having said that, let us rush. I know time is really running. We might not be able to capture everything we need today, but I'll try to be as fast as I can. So I also don't want to take much of your time. I want to release you early, and I don't want to bombard you with so many of information at a go. So let's just wind up a few slides quickly, then we look at another aspect. The good thing is that today is where we are covering a lot. Tomorrow we'll just be looking how do we prevent this thing from occurring. Now, there are some possible metabolic scenarios associated with cancer-related alteration in carbohydrate metabolism, include the following. So what really happens when the carbohydrate metabolism has been affected? That means that you are not taking adequate carbohydrate. So there is going to be increased glucose synthesis. So you find that the glucose that has been stored in the body, there is going to be so much of it being broken down. So that is what we term at increased glucose synthesis. Then of course we have decreased glucose turnover. So decreased glucose turnover, it means that the glucose which is supposed to be used for energy is low in the circulation. So you'll find so much of it being broken down. So we have that decreased glucose turnover. So that is something also that you need to learn. Just give me a few minutes. Give me a few minutes. Just a while. All right, so we can continue. So we are talking about decreased glucose turnover. Then, of course, we have increased core recycle activity. So I might not go through this. I'll be able to share these notes to be able to help you explain. Protein, what happened? We are not taking adequate protein, and your patient has cancer. This is what is going to happen. We are going to have increased rate of whole body protein turnover, decreased protein synthesis, skeletal muscle is going to be degraded. You are going to increase synthesis of non-skeletal muscle protein. So much of things are going to happen. We are not taking adequate of that. The same happens to fats also. That is going to happen. The fats, these are the changes that the body is going to experience. They are quite medical jargons, but they are easy to understand. Now, I want to go to another concept of what we call cytokinins and cancer cachexia. So this is going to be my last presentation. Then we take questions as we end today's session. So what happens when we have tumor? This is tumor. All right. What happens when someone has cancer tumor here? We are going to have several body organs being affected. And that is why we call it a multifactorial. Okay, so tumor is going to release what we call cytokinins. So we said cytokinins are chemicals that are released from the tumor itself, which has capability of interfering with normal metabolic process. So example of those cytokinins, we have what we call tumor necrosis factor A, alpha, we have interleukin 6, interleukin 1. So all these are referred to as the cytokinins. So now, the tumor is going to affect your brain, the central nervous system. So remember, when we are talking about appetite, is affected by your release of chemicals from your brain. So when you hear somebody doesn't have enough appetite, whether they are sick or not, it means that their brain is not able to give them a signal to trigger those appetite stimulating hormones, enzymes like what we call ghrelin, for example. So tumor is going to affect your central nervous system. This signals anorexia. Anorexia is loss of appetite. So the tumor itself will cause that loss of appetite. Number two, the cytokinins that are produced by the tumor is going to affect the muscles. So you are going to start having muscle wasting. The impact of this cytokinin is going to be felt on the muscles. Then also the cytokinin is going to affect the liver. That's why you find some of the cancer patients have their liver are enlarged, because we are going to have liver metabolic changes. So you are going to experience that kind of changes. So then also the cytokinins is going to affect the fats that have been stored. So you have fat use and depletion occurring secondary to that. And all this is what's going to lead to cancer cachexia syndrome. So it is important to understand that the only way to support this patient is that you need to make sure that you provide adequate nutrients that is going to build the immunity of the patient to be able to fight the aspect of this what we call the cytokinin. And that's why it is important to give this patient things like antioxidants, because antioxidants are able to oxidize these free ions that is called cytokinins. Is that okay? Joseph Koine, I'd like to hear from you. How are you doing this class? Koine, are you okay? Lynn Odero, are we following?
Yeah.
Quite interesting. Lydia Simiyu, what about you?
I'm following.
Oh, great. Mary Mwangi?
Yes, I'm following and have questions too.
Good. You can ask a question.
Okay, one of the questions is that you had said that there was a contrast between muscle loss during severe undernutrition and cancer cachexia, whereby you said in one of the two there is no visceral fat loss, which I didn't get so well. So I wanted you just to clarify
Clarification.
the same. Yes.
Oh, great. Thank you. Joseph Koine, I saw your hands up. I don't know if you have a question, so I can answer them together. Or you are okay. I don't know what your hands was up. Okay, so in case maybe you are not able to unmute yourself, you can just type. So, okay, thank you, Mary, for that question. It's good that you are following up. So what we are saying is that we have several types of wasting. We have what we call protein energy malnutrition, and this is affecting. Oh, Joseph, you're unable to unmute your mic. Let me try. Unmute. Can you try again? Now you're okay. You can ask a question, Joseph. You are unmuted now. Your mic is on.
Hello.
Yes, go ahead.
This class is so interesting. More especially, I'm really enjoying it.
Oh, okay.
Yeah, so my concern was about this glycerol. Now, since the triglycerides are in the process of lipolysis,
Yes.
they have been broken down to fatty acids and glycerol. Now, the glycerols are the one that enters through, can go that process of yielding a glucose.
Yes.
That is the cells can utilize. Now, I'm not getting well much about this glycerol. So when are these glycerol then being broken down, since they are going back to the cycle?
Oh, great. So what happens when they go back to the cycle? Remember, there's still fatty acids that are still free flowing. So remember, when we are talking about the lipogenesis and lipolysis, this process occur concurrently. So what we are saying is that you'll find fat being broken down through the triglyceride is being broken down, but then glycerol goes back to the circulation, finds another free fatty acids that are moving, combine it, and then they form the triglycerides. Then triglycerides get into the cycle. being broken down, glycerol being released, and that is how the cycle continues. That's why it is called Cori cycle or Krebs
Yeah.
cycle.
Message home.
Thank you. Thank you for
Okay.
that. Yeah. Great. Now, let me answer Mary's question. So, Mary, what I was trying to explain here is that if you take a picture, you remember there's a time in Kenya we had what we call Kenyans for Kenya. This was a fund drive to support children or people who are living in the the upper part of Kenya who were really affected by severe malnutrition, like marasmus, kwashiorkor, and those children. So what happens for those population? Remember, those children, they have been denied food. They are still under. They were going through starvation, and even the people who are living in those Turkana and northeastern areas. So their kind type of malnutrition is they also have cachexia, but their cachexia is not disease specific. It's food related. It's not linked by any disease, unless you find somebody who has cancer in that situation. So for them, you'll find that the body will lose both the visceral fat and also the muscle fat. What that means is that you find their organs are also being wasted. The fat that covers their vital organs like the heart, the liver are wasted. And something interesting, the feeding method for these two patients are different. And the mistake I've seen many people doing, they tend to manage these patients the same. So you find, for example, such patients like the babies who have severe acute malnutrition secondary to poor protein energy malnutrition due to maybe they are not adding, they are being starved because of food. The kind of the method by which they are being fed is through giving them what we call F100 and F75, the low energy dense foods. That is what we start with for them. Okay, so if you bring the same concept to cancer patients, you'll not be able to help cancer patients much because cancer cachexia is secondary to disease itself. Meanwhile, the other one is the food. So for the difference between the visceral, we were looking at the visceral fat. So for children or adults who are undergoing protein energy malnutrition due to starvation, even their visceral organs are affected. And that's why you find the functions of their liver is limited. They go through a process called reductive adaptase. Because they are not having enough dietary intake, their vital organs like the liver tend to adapt to that situation, then reduces its functions. The way in which it adapts is the function of the liver goes low. So it doesn't work adequately. And therefore, the fat that surround the liver and the heart are also being broken down. Whereas for cancer, the visceral fats are intact. They are not interfered with. Mary, is that making sense now?
Yes, a lot of sense. Thanks.
Thank you. So, is there any other question? I wanted us to stop there. It is quite a lot to capture within a short while. And I just wanted us to hang in there from there because I don't want to introduce the next subtopic which we are having. I just wanted us to stop at cytokinins here. And then, of course, now tomorrow we can look at stages of cancer cachexia. After we looked at the stages, then we look at how do we diagnose it. After that, then we look at management, and then we are done. So who has a question? Okay, Mary, go ahead. Yes, you can see your hands is up. And then Chetna. Mary, start.
Okay, there was a question that rose somewhere about the albumin levels of cancer patients, and also most of them experience hyponatremia. Would you please explain maybe the science behind why most of the cancer patients, experience low albumin levels and also the low sodium levels?
Oh, great. So now, in terms of albumin, remember albumin is a byproduct of protein synthesis. So if you are not, the cancer patients are going through catabolic process, that means the liver has no capability of producing enough albumin because there is no protein in the circulation to synthesize to be synthesized by the liver. So in that situation, when you do albumin test, you'll find that albumin is low. And again, if you correlate it with total protein, because I want you people to be very critical when you are looking at the liver function test, you'll find that when the total protein is low, then also you have hypoalbuminemia or low albumin level. So this occurs because the demand, as we've seen in this in our explanation, the demand for protein goes high, but the intake is low. So therefore, the body is breaking down what it has already stored. And remember, albumin is a protein in nature. So it is also being broken down it's being synthesized. So in acute phase of illness, you find there is usually hypoalbuminemia, even not for cancer patients alone, for any person who is, even you, God forbid, and you get sick, for example, you'll find that your albumin level will start going down compared to the where it was, because it is in the acute phase of illness. So to reverse hypoalbuminemia, you just need to increase the protein intake for the patients. I see in severe cases where we have severely low albumin level, we do IV infusion of albumin just to bring it up. But the long-term goal is just to provide adequate protein. So you avoid the negative protein balance. Therefore, you'll be able to start, the body itself will start synthesizing the albumin. So that is basically what happens. Then to your second question, hyponatremia, that is low sodium level, can occur due to so many factors. One is, as I've explained, the tumor has capability of producing its own hormones. Okay, so we call them hormone-like growth factors. So now, like, sodium is one of those hormones. Then remember, when you are having malnutrition, sodium is one of the extracellular cells. So they are found outside the cells of a human being. But when you have low protein level, you are going to affect what we call oncotic pressure, the pressure that causes the balance between the sodium and potassiums. So potassiums are usually found inside of cells, while sodium are found outside of cells. So that balance equilibrium is brought about by protein. So when you are not having enough protein, lipoprotein, for example, you are going to have the imbalance of sodium. So sodium will escape from an area of high concentration an area of low concentration, to an area of high concentration. So what happens is sodium will escape from the general outside, the extracellular, inside the cells. And thus sometimes you find these cancer patients being edematous. They have fluid overload. So that also happens. Another explanation could be when you are being starved, you are going to experience what we call refeeding syndrome. Okay, so refeeding syndrome is one of the things that you will experience when there's starvation. So refeeding syndrome is characterized by hyponatremia, low sodium level. So what it means that you'll find sodium escaping from extracellular area to intracellular, inside of the cells. The same happens to potassium. Now you find potassium escaping and coming out because sodium replaces goes out again from where there is a low concentration. So it's about what we call oncotic pressure. There is no balance between when we have low intake of protein, not even for cancer patient alone, but for even other patients who are sick. When they are severely ill, then we have imbalance oncotic pressure. Then sodium try to escape from extracellular to intracellular, and that's why they have hyponatremia. Mary, is that okay?
Yes, thank you.
Remember, also they might also experience that in terms of when they are not getting adequate diet of sodium. Let's go to, I see so many questions coming up. Chetna, you have a question, then I go to Kathomi. Chetna. Let's see,
Just
yes.
display the slide of Cori cycle.
Yes.
Because you just
But
skipped to another one quickly, actually. So I just want to see.
Oh, great. So you allow me.
Or will you share the slides again?
Yes, I will share the recording and the slides for review. So allow me tomorrow when we are starting our session, so we can start explaining the core cycle
Yes, yes, please.
in the next 3 minutes, so you get to understand it very well. Because I didn't want to really dig deeper into it because it's quite complex. But tomorrow I'll give it a priority before we start our classes.
Yeah,
So I'll
please.
share the slides plus the
Yeah,
recording for
thank you.
your reference.
Thank you.
Thank you. Kadomi, go ahead. Then Lynn Odero.
Yeah, my question is just from my observation.
Yes.
Okay, patients who have undergone chemotherapy and those that have undergone radiotherapy, those that do radiotherapy get cachexia so fast and they die too soon compared to those who do chemotherapy. Is
Okay.
there an explanation behind that? Yeah.
Yes, definitely there is an explanation. So the
Mm-hmm.
explanation is radiation therapy affects the mucosal lining of the gastrointestinal tract. That's why you find that before, especially patients who are having head and neck cancers, that is the cancer that is occurring at the head and also the upper part of the gastrointestinal tract, we insert what we call gastrectomy tube before they go for radiation therapy. The concept behind, we call it prophylactic gastrotomy tube. The concept is that we can be able to feed them via gastrotomy tube because the radiation therapy affect the mucosal lining of the gastrointestinal tract. What is this mucosal lining? This is the lining that protects the gastrointestinal tract. So when the effect of radiation is going to erode that part, exposing it to the radiation X-ray, and therefore you are going to have a wound along the gastrointestinal tract. Therefore, this patient, if they didn't have gastrotomy tube to be fed with, this patient will be wasted very fast. So number one is that the mucosal lining is going to be affected. Number two, they'll also have the inflammation. The radiation has the effect of causing several issues with the saliva in the mouth. So you'll have that they'll produce low saliva because it affects the gland, salivary gland. So saliva is important in terms of digestion from the salivary amylase from the mouth. Another explanation is that they also experience the inflammation of the tongue, what we call stomatitis. So when the tongue is inflamed, then these patients are not able to chew food. So that is the basic explanation compared to patients who are having systemic chemotherapy, which mostly sometimes they also have mucositis, but not as severe as those patients who are going through radiation therapy. So that is the narrative behind it. Before a patient is started on radiation therapy, especially when they have head and neck cancer, we insert the PEG tube, the tube percutaneous what is it called? Percutaneous tube. Yeah, just to make sure that they'll be fed via that. Kadomi, I think that has answered your question.
Yeah, thank you so much.
Thank you. Lynn Odero, I'm glad that you people are asking questions. This is interesting.
I just wanted to add on to what maybe you have said. First of all, regarding cachexia when patients are having radiotherapy, I think also because of severe vomiting and and diarrhea that comes off from radiotherapy, just a side effect.
Yes.
And then with regards to low sodium level, I think someone asked about low sodium level.
Yes.
I wanted to add, does severe vomiting and diarrhea could also cause the low sodium levels?
Yes.
And then also with some chemotherapeutic agents also cause bind to the micronutrients, also causes the low sodium levels.
The low sodium level. Exactly. Yeah, true. That is also a very perfect explanation, and I'm glad for that input. Yes. So remember, when we are having radiation therapy, it's also going to affect the normal flora, the bacteria in the gastrointestinal tract. Therefore, patients who have undergone radiation therapy, they experience severe diarrhea and also, of course, vomiting because of that. And so that is why sometimes they have so much effect. Compared to patients who are undergoing chemotherapy, we cover them with ondansetron, which is able to prevent them from vomiting. So thank you very much, Linodero, and I totally agree with your explanation. Is there any additional question? I think, team, we can end it from there today. Then tomorrow we pick from where we left. So tomorrow we are starting at, we look at a little bit of Cori cycle to explain it a little bit. Then we look at the stages of cancer cachexia. Sorry, I think my network, I lost a network. Mr. Nyariki, are you still there? I wanted to hear from you. How was the class? Okay. Are you able to hear me, class? I hope you can hear me.
Yes.
Okay. Mr. Nyariki, you are there? Cherono?
Yes, yes.
Any comments before we close? All right. Cherono, do you have any comment? You've joined it, but I'll share the recording. All right, so I think we end it there for today. It was quite interesting to learn. I hope that tomorrow we'll be able to capture as much as we can. I pray that we be able to really join early so we can start early, and then we cover as much as we can before now we end the session. I'll be able, after the sessions, we'll be issuing certificates for this 2-day participation. So that will be something you do. And also tune in on Thursday. I also have a webinar with Kenya Society of Hematology and Oncology. This is a society where I'm a member. It's a combination of all oncologists. We are starting at 7, exactly 7. So please keep time. So this is a platform, a forum for all the oncologists in Kenya and specialists, and I'll be able to present something on nutrition and cancer. So I hope you'll be able to join on Thursday, 7 p.m. I'll have a webinar there. We'll be able to share the link early for you to join. It will be through Zoom platform. So I'll be able to share the link in our WhatsApp group so you can join on Thursday. Thank you very much. Have a lovely evening. God bless you for joining us. Let's see what we can cover tomorrow. Have a lovely, lovely, lovely evening. Thank you. I'll share the recording and also the slides for your reference. Thank you.